So Dr. Khatib and Dr. Lamba and everybody, we're going to go ahead and get started. Thank you to everyone who submitted questions ahead of time. We will get to those at the end. And if you have any questions, you can use the chat box, or you can also unmute yourself, and I will we'll make sure to address everything by the end of the session. So without further ado, Dr. Khatib and Dr. Lamba.
All righty, thank you, Noor. And good evening, everybody. I'm Yazan Khatib. Know many of you, and Dr. Lamba, my partner, also knows many of you, and we look forward to make this an interactive session towards the end. Otherwise, kind of explain to people over the next 20, 30 minutes what is clinical research about and what our involvement with it has been so far. So so the first question is really why clinical research and why clinical research outside university settings. Most of us probably think that clinical research, in other words, the research that leads to the new medications that are coming up every day that help patients, or the new stents or the new devices, happens only in university settings. And that's actually true at the benchmark, at the bench setting when a new tool has been developed. But once a new tool is developed, as the FDA tries to figure out if it is actually going to work out or not, they seek the participation of many practices across the nation, and we happen to be one of those. And most of those who actually participate are not in the setting of a university or an academic setting, but are doctors who still have academic interests. And so, so in that capacity, having participated in research since 2007, shortly after we started the practice, we have witnessed firsthand how it actually does enable access to advanced treatments to our patients well before those treatments are approved by the FDA, which is a very rigorous and time-consuming process. Examples I listed here on the slide that you probably are able to see are things that we were part of, and we will elaborate on later. Certain stents in the legs that help reduce the chance of recurrent blockage, certain devices that have been proved to help with heart failure patients, certain medications and devices that help prevent strokes. We were part of all those research projects while they were still not FDA approved.
Of course, it's all coming out of here.
And our patients who were able to participate in that research were able to reap the benefit of having access to early treatment before it is FDA approved. So Dr. Lamba, give us a little background, please, about.
So hi, thank you for joining us this evening. We'll try to keep it interactive, as Dr. Khatib said. So as a patient, if I am asked, or if as why clinical research, as Dr. Khatib pointed out, so from a patient standpoint, it is absolutely a win-win situation. So as a patient, when you get enrolled in a clinical trial, one of the mandates is that you are on optimal drug therapy. We call it guideline-mediated drug therapy, or GMDT. So any clinical trial, and we'll talk about one where there are very strict criteria where the investigators find out what medicine the patient is on, why they are on this medicine, and why not. So you are on optimal therapy, and as you get followed in that clinical trial, you are much diligently followed by investigators as well as research coordinators by way of clinical visits and phone calls. So most of us have been in clinical trials for the past 20 years. I started this in 1990s. At FCCI, we have been doing this for the past 13 years. And as you can see on the slide, we have enrolled 3,000 patients and participated in many clinical trials. So if Yazan, you want to chime into what I said about
so basically, typically when we're taking care of the patient, we are always doing the best we can to make sure that they're followed closely. For most patients who are straightforward, the every 6-month follow-up is quite adequate. The every year follow-up is quite adequate. For some of the patients that are at extremes of illness, and thank God not many are, but for the few that are at extreme, who happen to be usually the best candidates for clinical research. Then on top of the visits, which we, for those patients, scale at a much more frequent routine, usually just to keep them out of the hospital, keep them compensated. Then on top of that, if they're part of a research protocol, they also get hounded. And yes, the word is hounded, with a lot more calls from the research coordinator, which actually turns out to be a very good thing, because then even if a patient is not getting an investigational drug or an investigational new device or stent, they're still getting hounded with the clinical coordinator, research coordinator, so that if there is any problem, it's picked on very early and it's addressed before it becomes compounded to require a hospital admission or something like that. And so that's a substantial element of the why we chose to be part of clinical research as an organization. This is a busy slide that I'll let Dr. Lamba kind of explain a little bit more. A lot more of the clinical research we're involved with has got to do with heart failure, even though we're involved with many other research protocols. And Dr. Lamba, as many of you know, have been our not just know-how guru, but just absolutely heart passionate doctor about heart failure management and improving the life of the patients with heart failure. So tell us, please, Dr. Lamba, a little more about.
Yes. So as a way of introduction, we know that there are more than 5 million Americans living with symptomatic clinical heart failure, and there are over 1 million new diagnoses or hospital admissions for heart failure
Every year.
Now, every year. So what causes these hospitalizations? So clearly, despite all the advances that we've made in the amazing medications and devices for congestive heart failure, there is still an unmet clinical need. So these patients are ending up in the hospital. The common denominator for these patients coming to the hospital is, to keep it very simple, is their lungs fill up with fluid, the timing of which determines how quickly they make it to the hospital. Somebody's blood pressure goes up severely, they eat a lot of salt, they retain salt and water. Sympathetic activation, for whatever reason, causes this pressure to increase in the left side of the heart, which then is the pressure into the lungs. The lungs get filled up with fluid. That's what brings the patients to the hospital. It's, you can't breathe, you're short of breath with fluid in the lungs. Now, the rest of it, the swelling of the legs and the bloating, all that comes on slowly and can be managed as an outpatient. But this sudden increase in pressure, which causes the lungs to flood, if there was a way to identify this early, or a way to intervene when this pressure starts to go up to prevent the lungs from flooding with fluid, that's what we are aiming for. So in congestive heart failure, we got very good at identifying the bad players or the bad hormones that cause the heart failure, and we've targeted those. So you're on medicines like Coreg or beta blockers, medicines like Entresto, like Sinopril, Losartan, but we've reached a pinnacle, we've reached a ceiling. Beyond this, we need to be extra smart to figure out what we can do to prevent this sudden increase in pressures and the lungs filling with fluid. So we'll talk about this a little bit.
That's right. And so so to backtrack, so why clinical research? I hope people really understand why it's important, the benefit of it. What is clinical research? Clinical research is basically this is not when we are reinventing a new treatment modality. That usually is bench research. But once a new treatment modality has been invented and has been through the initial phases of research, what's called safety and feasibility, after it's gone already through animal trials, then once it's safe enough in the FDA's eyes to be given to enough people to verify whether it really does work on a large scale, that's where these are the trials we participate in. So usually the modalities have already been vetted substantially from a safety perspective. And the question really is more, are they really as good as they claim to be in terms of improving the patient as much as they claim to? Because obviously there has been many drugs and devices that were invented and then didn't pan out. as far as the benefit. So the way we conduct research usually, most of the time, is through one of two modalities. Either of them will be already run by the FDA, approved by the FDA. And then when we as doctors and as research coordinators identify patient X that we feel is a good candidate for such protocol, then we discuss that with the patient. The clinical research studies are one of two kinds. There is a kind that's called randomized, where, and those are how they're designed is all mandated by the FDA. It depends on what the FDA is trying to prove out of particular research. So in a randomized protocol, basically the patient will come, will understand what the new modality will do for them. They will consent, but not the patient and not the doctor will know whether the patient will end up getting the new investigational drug or whether they'll get a sugar pill, what we call placebo, or whether they're going to get the new, let's say, defibrillator or new stent, or they're going to get just a good old defibrillator and stent that have already been approved. So this is a randomized trial pattern. There's another type of research where there is no randomization, where all the patients get the new device or the new drug, and then we just monitor their reaction to that, their blood work response, their clinical response, how they feel. And so both types are conducted at FCCI and other organizations that participate in research, but you do need to be aware that there's two differences. Now, who and how we choose to enroll in a clinical research, again, we know what research protocols are available to us for different disease states, for blockages, for heart failure, for stroke risk patients. And then when we are meeting the patient, if it's a patient who's already doing extremely well on their current regimen, usually we don't approach them about a research protocol. But if it's a patient who we feel could attain a little bit additional benefit, and our knowledge base so far of the new protocol is one where it seems like the risk outweighs the benefit, then these are the patients that we offer research to. When we do offer research, participation to a patient, it is entirely the patient's right to choose to participate or not. We have no ego into this. We have no dog in this fight. We obviously like to see more patients enrolled so that we get faster answers about whether certain protocols are or are not helpful. But we are fully respectful, not only we, all researchers are very, very objective about this. There is no I in this. It's all about you, the patient. And so if the patient understands and fully consents, then we proceed. Sometimes the patient consents, and then through our vetting process, we find that that patient is still not actually good. So we withdraw. We call them a screen failure. Okay. But at the end of the day, we keep going down that path so long as the patient really is interested in pursuing it. And typically we don't offer it unless we are already convinced that it is helpful.
So let me point out here that it is these research clinical trials through which we come to know what is the best way to treat the patient. So for example, if somebody has a heart attack or somebody has congestive heart failure, what medication should be they on? How should they be treated? When should they be taken to the cath lab? All these conclusions and guidelines have come from cardiovascular medicine randomized controlled trials. In this regard, cardiology has made great advancements, progress in determining on trying to figure out what is the optimal standard of care for any disorder, any cardiac disorder. So that information we are greatly indebted to randomized controlled trials. It's not just, you can say, oh, why do you do this just cause, that's not an option. So this is because the data shows this.
That's right, absolutely right. So some of the research protocols that are currently offered at First Coast Cardiovascular Institute are research protocols geared towards patients with advanced heart failure. Research protocols that are geared towards patients who are struggling with blockage in the heart vessels or in the leg vessels. We have participated in the past with research protocols that aim to reduce the risk of stroke in one way or another, either through medication or through interventions with procedures. So one particular protocol that's truly absolutely amazing that Dr. Lamba has been involved in from the outset. And to my knowledge, First Coast Cardiovascular Institute was the first participant in the state of Florida, is this concept of the V-wave interatrial shunt that helps patients who have advanced heart failure. And I'll let Dr. Lamba explain a little bit about it. It's basically, as some of you or many of you would probably remember, the heart is made up of 4 chambers. And the upper chambers, the atria, collect the blood from the body on the right, from the lungs on the left, and then they push it down to the lower chambers, which are the ventricles, which are really the pumps, with the right ventricle pumping the blood to the lung, the left ventricle pumping the blood to the rest of the body. And like Dr. Lamba explained, when patients with heart failure struggle, it's when their pressure within the upper chamber goes too high to where the blood backs up into the lungs and they get into what we call pulmonary edema. They get really winded. And so this research protocol takes a patient who's already tried everything, had their defibrillator, had maximum medications, and is still struggling, and then is testing the hypothesis whether we can do more to improve their symptoms and reduce their hospital admissions. So I'll let Dr. Lamba explain about it.
So this is a really cool concept. Okay, so I'm going to go forward one slide, and this may sound a little technical, but remember when I said that, if we can identify or if we can prevent the fluid from getting into the lungs acutely, we can prevent hospitalization and congestive heart failure. What this graph basically shows that with a little change in volume of a particular chamber, you can get a large change in pressure. So when the pressure, so let's go back here. So when you see this, the left atrium is the left top chamber, the right atrium is the right top chamber. This is a little, say, stent, if you will, a stent that we put in this little membrane that separates the 2 top chambers.
It's more of a one-way valve.
Yeah.
Let's call it a one-way valve, really, is what it is.
Right.
And it's implanted as a stent, but at the end of the day, it's a one-way pop-off valve.
Correct.
In simple terms, it's a one-way pop-off valve.
So when the pressure on the left top chamber goes up, a little bit of blood, say 10 cc's, 10 ml, goes into the right top chamber, and that markedly decreases the pressures in the lung and in the left top chamber, the left side top chamber, and prevents the lungs from flooding with fluid. That is the hypothesis, and that is what we are testing. So when patients with class 3, which is they get symptoms of congestive heart failure, they're either fatigued, short of breath, on mild amount of activity, on optimal medications, you're on your Coreg, you're taking your Entresto, lisinopril, aldactone, what have you, you are then eligible to participate in this clinical trial. The beauty of this clinical trial is that as a principal investigator, and you as a patient and me as a principal investigator, neither of us will know whether you have the device or not for 2 years. So the person who's putting it in is the only person who will know whether you got the device or not. When you go in for the procedure, you'll go in for a hard CAT and come out of there not knowing whether you got the device or not.
And the reason for such what we call blinding, okay, so the patient and the doctor, treating doctor, not the researcher in this instance, are blinded to what treatment was received is because there has been history of procedures and devices that the doctors and everybody thought logically will make the patients live longer or feel better, that actually over time through rigorous research turned out not to pan out as a positive outcome. So we learned that, so that's why the FDA mandates on certain products that the patient and the researcher does not know what device the patient received, whether they received it or not, so that when the patient comes back and say, oh doc, I feel a lot better, then there will not be the bias from the patient or the doctor of knowing they have the new modality that might make them believe he's feeling better or she's feeling better. but rather than when the patient says I'm feeling better or I'm feeling worse for that matter, that it's really a very objective validation as to whether that device did or did not work. So in this particular instance, the concept makes perfect sense. You know, we know that how when the pressure increases in left atrium, patients could get overwhelmed with symptoms very quickly. So a pop-off valve that can release the high pressure in a short notice, instantaneously on demand, but then close again when the pressure is normal, okay, or near normal. It's a very revolutionary concept. Now, whether it's going to pan out or not, we obviously don't know, nor does the FDA. That is why this is not a treatment modality that I would recommend to the average Joe on the street, because we still don't know that it works. But for those patients who are already struggling, the concept seems so reasonable. The procedure risk of implanting this seems to be fairly low risk. Then for the right patient, this will be something to consider. And this is just, we cite this as an example. There's many others, okay? But that's so Dr. Lamba, for example, will share with you that in this particular protocol, we have had what the FDA mandates that the first 2 patients we implant, we actually know whether they received it or not. And in the first 2 patients where he and Dr. Ali have implanted this, you tell them the story.
So yeah, so this patient was referred to me from out of town, where Dr. Raval in Orlando actually recommended, and was a second roll-in patient, was very limited by congestive heart failure. So we do what is known as a 6-minute hall walk test. So we ask you to walk at your own pace for 6 minutes and see how much distance you've covered. If you walk between 150 to 450 meters, you have symptoms of class 3 congestive heart failure, and you can qualify for these kinds of studies. So just as an example, this gentleman was able to walk 150 meters. We got him the device. He came back after 4 weeks, and we did the 6-minute hall walk test again. You will not believe it. He walked 950 meters. That is about as much improvement I've seen objectively with any device or any therapy in congestive heart failure in 25 years.
I mean, that's virtually a 500% improvement.
But as Dr. Khatib says, all the more reason that we have to rigorously test this device, being blinded over 2 years to see how patients with the device did, how patients without the device did, compare the two, and then figure out, does it actually, number 1, improve quality of life in patients with heart failure? Number 2, does it improve their survival? These are 2 very important questions.
And number 3, does that improvement that Dr. Lamba, for example, witnessed in this one particular example, is that going to last, or was this just a one-off for 4 weeks or 8 weeks? We don't know. The logic is one thing, the application does not always follow. So that's why clinical research. So I think
and Drs. Khatib and Lamba, I am getting a few questions about the device. So Sean asked, would the device be more likely to clot?
No. So in all the preclinical trials of almost 1,000 devices, there has been no. So essentially what it is, Sean, it is a PTFE graft with nitinol wings. So there is no metal, or there's nothing to cause a reaction for either thrombosis, or it'll just be covered by endothelium.
And then Samantha also asked, would the group require anticoagulation, both the cath only and the device patients?
Plavix for a month.
Because the whole idea again here is that the majority of the device, except the valve itself, will get endothelialized. What that means is it will get covered over time with the same tissue that covers, that lines the inside of the heart and that prevents clot formation. So that's why the blood thinner Plavix is required only for that short period of time. But then again, that's what we're learning during the research. I mean, if there's, for every research protocol, there's a very involved, what's called data safety and monitoring committee. And if they start to see any untoward effects, then they might decide that we should do Plavix for 2 months. obviously with 1,000 patients enrolled in studies, they've already come to cover that answer. But that's a good thing to also mention.
So the next thing we have is actually a sensor, which we've had for 5 years. And here we are measuring pressures in your lungs, and then we give you a call or text. We get in touch with you to change your medications to prevent, because there's a certain lag time between the pressures going up and the lungs actually filling with fluid. We can identify that. So what you see on the slide on the left is this little sensor, a small sensor made of glass, gold capacitor, and these nitinol rings that we, through a hard cath, right hard cath, we put it in your lung artery, and you go home same day. You go home with this console, and then we have access to the secure website. So you lay on this pillow every morning, you press a button, and it sends us the pressures in your heart and your lungs instantaneously. So we've done more than 150 of these, and we're doing the pivotal trial to show that patients actually live longer. It's already approved, and we've shown that it improves quality of life. So we're doing a survival study for the FDA before it gets universal approval. So that's called the CardioMEMS device.
And one thing worth pointing here, so that's an example of yet a different type of research. So this device has already been approved by the FDA, okay? But now we're trying to see whether it's approved just for symptom relief and reducing hospital admissions, which is what it's approved for now, or whether it in fact does also amount to a better survival for the heart failure patients. So this has already been cleared by the FDA. And you wouldn't know it from Dr. Lamba being too humble, but Dr. Lamba was the first to implant this in the state of Florida, and is considered one of the authorities on this device across the nation. He's very passionate about it. We have, obviously there's fun with this device. It's a very expensive technology. So they really need to prove that not only they make you feel better and reduce your hospital admissions, but that actually for that price tag that they actually do improve your survival. And that's what Dr. Lamba is working them on.
This slide shows where it goes in the lung artery. A very simple procedure, right heart catheterization. This is just clinical data showing benefit. We've had a 50 to 70% reduction in hospitalizations over the years with this device compared to needed to treat is only 4 to prevent a hospitalization. So it compares very well with other therapies. You want to talk about?
And this is another research that we're participating in. This is not really earth-shattering research. For patients that are on with us tonight, when you get a stent, you have to go on the Plavix and the aspirin. We used to say forever, and then we trimmed it down to a year. And now we seem to be trimming it down further because there is a risk when you go on aspirin Plavix that the risk of bleeding goes up a little bit. Of course, if you don't take it, the risk of clotting of the stent also goes up. So this stent is a new stent platform that is trying to venture to see for those who cannot take aspirin Plavix for a sustained period of time, for at least 6 months, whether they can have this stent and just go with the aspirin Plavix for less than 4 weeks and move on, and still gain the benefit of a lesser chance of recurrence. And we don't know the answer. We know the stent itself is good, but we don't know if it's going to perform long-term as good as the drug-eluting stents that we already have on the market, already approved by the FDA. Usually we consider this research for somebody who has a surgery that's urgent in need, it really needs to happen soon, cannot wait 6 months or a year of aspirin Plavix, and they have a critical blockage that they cannot go under general anesthesia without fixing. So that would be a nice bridge here.
So I think for sake of time, we have several other studies.
And this is, many of you are familiar with Xarelto, the blood thinner on the market, and we're proud to be part of the research protocols that led to its approval. We hope to be able to convince the companies to reduce its price, but otherwise it definitely proved to be a successful medication. We had it available before it was FDA approved through a particular research protocol. And, for patients who have very advanced blockages that could not be bypassed through open surgery and that could not be stented through conventional techniques. We're also very proud to offer a research protocol where we literally perform a bypass through a catheter, in essence. So as you can see here, the red is the artery, the blue is the vein. So in this protocol, we actually exit from the artery into the vein, turn on a bypass graft, and then re-enter from the vein into the artery. The yellow here and the slide is the blockage. So in a way, we bypass the blockage with a bypass material very similar to what's used in an open bypass, but it's done through a catheter. Seems promising. We still are lacking long-term data. That's what the research is for, to verify that that indeed does provide long-term outcome. This is a research protocol that we're pretty much finished. This is a dissolvable drug-eluting stent for the legs. It's proved to reduce the chance of recurrent blockages in the legs when we fix them. And it was available for our patients 2 years before it was approved by the FDA because we were part of that research protocol. So research really does offer a substantial advantage. Now, having said all that positive stuff about research, there's definitely a word of caution here. Research always involves dealing with equipment either that is not already approved by the FDA or that is approved by the FDA but not for the particular indication we're trying to use it for. So for example, Dr. Lamba, again being the heart failure guru that he is, has been telling us for a long time that some diabetes medications are indeed very helpful for some heart failure patients. Honestly, I was the skeptic until finally, we just finally got an FDA approval for one such medication that not only is helpful in diabetics who have heart failure, it's helpful in heart failure patients, period, whether they're diabetic or not. And that medication was only approved as a diabetes medicine in the first place. And so, on the other hand, some other products really went through research and did not pan out or proved to have a complication that forced the study to shut down and stop the research at that point. So always there has to be the balance, the benefit risk analysis as we balance. So I thank you all for your participation, and I'm very privileged to be alongside Dr. Lamba on this conversation and would like to open it for questions.
Dr. Lamba?
Yes.
This is Cheryl. How are you doing?
Oh, good. How are you? Good, Shereen.
Well,
yeah.
let's put it this way. Have you told your friend that I am a survivor of a triple stroke? And I don't know of anybody who's ever had a triple stroke. I've heard of one, maybe two, but a triple?
You've done very well, and we're very proud of you.
Well, I've done very well because of you, sir, and I recommend you a lot. Now, my question to you is, my major problem at this point still is vertigo. And I don't know if that's got anything to do with anything, because it gets to the point it is uncomfortable for me to walk a long distance. I can use my walking stick, but I'm not comfortable. I mean, so I'm not going to pass out.
I would say that we reserve this discussion to a private conversation.
Okay.
And feel free to call me anytime. Or
I will do that. Okay, thank you.
Yeah, yeah. Questions?
I guess that means we were either too boring or we were too clear. But I'll just assume that we were not too boring. I hope this was helpful. Just to explain what clinical research is about. It's something that's not only available at FCCR. Our mission and vision statements specifically state that we are here not just to treat people, but to advance medicine. It's also available in many other large practices. And I hope that people who attended this will look at clinical research with a favorable view, whether here or elsewhere, because A, that's how we get new products and new treatments approved. And B, as many times, especially for those who are at extreme of illness, okay, that's how they get access to potentially promising technology at the time where it's still not FDA approved.
Dr. Khatib, this is Fuad Shaban.
Yes, Dr. Shaban.
I just want to ask, can any of these experiments be performed on a very senior citizen? Does age have anything to do with this?
Very, very good question. And so every protocol has its own what we call inclusion exclusion criteria, and those do include age. And so we have some protocols that enable basically, you know, anybody above the age of 18 up to 80, up to 85, up to 90. It depends on the protocol, Dr. Shaban.
Very good. Thank you very much.
Absolutely, good questions. All righty, very good. Noor, do you have any wise comments?
Yes, well, we have lots of questions, Dr. Khatib. Don't go just yet.
Okay.
Yeah,
Okay.
so Jim asked if you ever remove a stent, or does it stay there indefinitely?
Great question. And so I would say the vast majority of the time, if a stent gets in trouble, we fix it while it's there. We are rarely ever remove a stent.
Okay.
But stents do get in trouble, about depending on where they are, in 5 to 20% of times, and they get fixed while they are in place.
And then along the same lines, Elsie asked, the CardioMEMS device, is that ever removed?
None has been removed to my knowledge clinically. It's inert, it becomes part of the body. About 10,000 devices have been implanted in the US, not a single case of pulmonary embolus or clot formation, so completely safe.
And what you have to understand is that the CardioMEMS device, the pictures you've seen, the size of that device is really about as big as the tip of my pinky finger.
Yeah, it's very small.
So while it might look big on the slide, it really is a very tiny thing that gets embedded in one of the branches of the lung vessels, and you don't even know it's there.
Thank you, Dr. Khatib. And then John asked about the requirements of the patient's time and duration of the tests for clinical trials.
Great question. And that too is extremely protocol dependent and is usually very clearly spelled out to the patient.
Mm-hmm.
So we have protocols that are very short. You know, these are not common, but are 3-month to 6-month follow-up where the FDA is trying to establish a very particular focal point. I would say most protocols usually are somewhere between 2 and 5 years of follow-up. What that means to the patient is, you know, what the medication, you know, that's been tested, which usually is tested medicine for a year. They just have to allow us to continue to have our research nurses call on them, check on them frequently for the duration of the protocol follow-up. Now, that all said, the patient has the right at any point in time to just withdraw from a protocol. But we just don't like that because it really pollutes the data of the research. So we want to be very transparent on what the expectation is on follow-up at the get-go, that we hopefully have very few people withdraw later.
In general, more intense a study protocol, more the patients are compensated. For example, we are doing a study called Anthem, which is a vagal nerve stimulator for advanced heart failure. It's pretty intensive that patients have to come in every week for the first 8 weeks, and they are paid $50 for every visit for their time, for 2 hours for every visit.
Okay, wonderful. And then Gerald asked about the best medicine for blood flow.
What's that? I'm sorry, what's the question?
The best medicine for blood flow.
Blood flow.
There's no medicine for blood flow, Gerald. Blood flow is a function of how open of a vessel you have and how good of a pump in the heart you have. So we don't have medicine to improve blood flow. What we do have is when we control your blood pressure and avoid the blood vessel from being too constricted, we improve your blood flow that way, right? If you are somebody who's prone to clots and we thin out your blood for that reason, then we avoid clots clogging the vessels. As long as you have an open vessel, we cannot really control the flow itself. Do you agree with that, Dr. Lamba?
Yeah, it's a determinant of your. But also, if you can come up with something like a coronary dreno for blood vessels, it will be a boon for humanity, and you'll put us out of business, and I'll be very happy.
Thank you so much. And then Ralph asked, is there any new research as continued benefits of taking fish oil?
Great question. And basically, the only fish oil that had proven benefit, okay, or fish oil product that had proven benefit in terms of reducing blockages and improving the cholesterol profile is the pharmaceutical grade, unfortunately, very expensive fish oil and the brand name medication. It's disheartening because expensive medicine. Otherwise, all the stuff that you see on the market, otherwise as a generic fish oil, to my knowledge, you correct me if I'm wrong, has never proved any benefit to help with anything, unfortunately.
So I have a take on this. You know, it's past 70 years we've been doing clinical trials. No vitamin has ever been shown to prolong survival, prevent a disease process. Yet people say if you eat fruits and vegetables, they're good for you, right? So my take is that anything that's synthetic is probably not as good as a natural substance. So in that regard, eat as much tuna and salmon, mackerel, sardines, if you like. But those are the fish that have the most fish oil, omega-3, omega-6 fatty acids, and are beneficial to the heart.
Thank you. And then Katie asked, how are studies chosen?
How are studies chosen by, okay, so we as a practice, when we get approached by a pharmaceutical company or a stent company about a device, we first of all vet that study. We don't accept every one of them. Some of them, we are not convinced of the safety profile or that the promise is as big as, because there are many devices that have gone to research and failed. And so we do our own clinical due diligence first. If we feel that, there is a need here, and we think that this is going to be helpful, this is likely going to have more benefit than harm, okay, then we go down the path of bringing it on board. Does that make sense? Does that answer the question?
Yes, thank you. Katie, if you still have questions, you can message us. Christine asked, when you refer to blockages, are they the same as narrowing? And if so, what degree of narrowing would warrant treatment beyond medication?
So yeah, absolutely. I mean, blockages are narrowing. The medical term is atherosclerosis, hardening of the arteries. Basically what they are cholesterol literally seeping under the vessel lining and starting to narrow the vessel through the vessel wall thickening, okay? So yeah, it's different name, but it's the same process. Typically, we do not intervene on a blockage unless it exceeds 70% narrowing, that is. There are occasions, however, where there are exceptions, certain types of heart attacks, certain types of bypasses, but typically we do not intervene on a blockage unless it exceeds 70%. Do you agree with that, Dr. Lamba?
Absolutely. Yeah.
And obviously, the best intervention is living by guideline-directed medical therapy. So making sure cholesterol stays good, blood pressure stays good, then there'll be a lot less chance that the blockage will develop in the first place. And if it develops, the chance of it progressing to a critical stage in the second place.
All right, thank you. And then Tom asked, what's the latest on transcatheter mitral valve replacements?
Great question. So Dr. Lamba, so believe it or not, cardiology has advanced so fast in the past 25 years of my and Dr. Lamba's practice to where even within cardiology, now we have sub-specialists. So, it used to be that cardiology will be interventional, the plumbers, electrophysiology, the electricians, and then the general guys and ladies. And now, even within the interventional side, we have gone into sub-specialties, what's called the structural heart folks. So Dr. Al-Sagir and Dr. Ali in our practice will be best suited to answer that question. I can tell you that we are already doing transcatheter mitral valve repair. What that means for the audience out there is mitral valve replacement and repair used to mandate opening the chest. No longer that's the case. We can now go through the groin for mitral valve repair in certain patients, okay? The next thing we're looking at is the development of an actual valve for those who cannot get repaired through the catheter, where we can deploy the valve through the catheter. Now, I don't think it's far from now, but I think it's still going to take a little bit more time. Luckily, in the aortic valve, it's already now standard of care, and it's happening every day with absolutely excellent success, and with patients going home within 24 hours, no split chest, minor wound in the groin, and that's it. For the mitral valve, I think it's still going to be another 2 to 3 years in the making, but I don't know the right answer in detail there.
Yeah, there are programs where they are doing this routinely. They're the bigger centers, select centers,
and again, through a research protocol.
Research protocols.
Yep.
So that's how it's going to be proven. And now, you know, the aortic valve is found superior to surgery, even for low risk. But all that data, again, came from randomized controlled trials, and therefore the need. So.
Thank you so much. And thank you, Ralph and Dwight, for sharing your very nice stories about Drs. Khatib and Lamba here in the chat box. I'll make sure it gets to them. Jeremiah asked, does snoring affect your heart?
Yes, big time. So I think obstructive sleep apnea is very unrecognized as a risk factor, not just for pathogenesis of congestive heart failure, pulmonary hypertension, which is high pressure in the lungs. But have you ever wondered why people have heart attacks in their sleep? It's because they don't get enough oxygen. So the majority of MIs are heart attacks. So essentially, when you stop breathing, when you get apneic, you don't get oxygen. And so your oxygen levels drop. And so that increases the bad hormones in the lung and systemic circulation, then increasing your blood pressure, increasing pressure in the lungs, and increasing the myocardial oxygen demand. And if your supply isn't enough, that can precipitate, tip you off to have a heart attack. So if you are getting up in the morning and you're tired for no reason, and if you feel you haven't had enough good quality sleep, if obviously you're snoring a lot and you know you're falling asleep during the daytime, please tell your doctor, and that you may have sleep apnea. Yes. Yazan?
Yeah, and the only one thing I would say is, as we're witnessing a real, overweight epidemic across the U.S., we're all now overtaken with COVID, but we have had an overweight epidemic for a while. Sleep apnea is a direct byproduct of gaining weight. And it is definitely, no question about it, must be treated. Now, for those folks who can really lose drastic weight and lose the sleep apnea was losing the weight, that's perfect. But for the many others, they have got to get it treated.
Okay, and then on the subject of sleep as well, so Helen uses a CPAP machine, and she's wondering, does having to use a machine mean she has heart disease or she's at a higher risk of heart disease?
So I would say to Helen, she should ask her doctor, because there's a lot of nuances here, okay? A 30-year-old person with sleep apnea is different than a 55-year-old person or a 70-year-old person with sleep apnea. A person who also has diabetes and high cholesterol, yet at a different spin. So the major risk factors of cardiovascular disease are still smoking, cholesterol, diabetes, cholesterol, hypertension, okay? These are the real strong, big ones, okay? Of course, sleep apnea adds to it. Of course, obesity adds to it. Of course, all the other factors, family history. So you have got to kind of know your risk profile and tackle all the ones you can. You cannot change your family history, but all the others you can tackle very aggressively in today's medicine. I hope I answered your question. By the way, we do have a very good sleep doctor, Dr. Thielman, on staff, who is fantastic. And I will just say transparently, we have sleep medicine here, and from a business perspective, it actually doesn't make sense because we actually lose money on sleep medicine in our practice, but we choose to keep it because we really believe it plays a substantial role, if not treated, in patients who have AFib, in patients with arrhythmias, patients who have heart failure. It has tremendous role to play there.
Okay, and then Gilbert asks, can blockage be reduced without using a stent?
Without using a stent?
Mhm.
Oh, absolutely. Yeah. Here is the deal. More important than reducing the blockage without using a stent is the fact that we can definitely stabilize the blockage. Because if somebody has a 50% blockage, they're not going to have symptoms from that. But guess what they will have is if they continue on the lifestyle that led to the blockage to happen in the first place, what might happen is worse than the blockage getting more severe is that that blockage might suddenly rupture and create a sudden event, which could be a stroke, a heart attack, a sudden cardiac death. In people who really take the risk profile aggressively and seriously, that 50% blockage might regress to only 45%, which is not a big difference, but importantly, it becomes what's called a stable blockage. In other words, a blockage that does not rupture and will not cause sudden death, will not cause a stroke, will not cause a heart attack. It'll just be there. And we don't really, excuse my language, we don't care about that one. It's not going to affect the patient adversely. So definitely, vigorous risk factor modification will pay huge dividends. Do you agree with that, Dr. Lamba?
Yeah, I think there are more of us in this community that are being convinced that to cause regression of atherosclerosis, in other words, what you said is reverse that process, you have to turn vegan. Now, I like meat, so, but there are my colleagues who are absolutely giving up animal protein and are convinced that, turning vegan is the way to regress. But whatever be Mediterranean diet, fruits, vegetables, whatever you employ, I think the whole idea is to prevent this inflammation, vascular inflammation, and cause regression of blockages.
Right. Thank you. We're winding down on questions, so if anyone thinks of anything, please use the chat box. Andrea asks, is it possible after a certain amount of time your body builds up tolerance to blood pressure medication and it no longer works effectively?
Some certain agents, but for the most part, with ACE inhibitors, beta blockers, that's not true.
I tell you what I see personally, anecdotally, more so is that as we're getting older, we all have the propensity to gain weight. Okay, so a blood pressure medicine that worked very well for me when I'm 180 pounds or 160 pounds, I'm going to need either more of that medicine when I get to be 200, or I'm going to need to add one more medicine. And it's not that the medication is failing, it's more so that my body has changed, or I've started to become more lenient with the salt and sodium intake. So frequently that becomes much more of an issue than kind of, the medication losing effectiveness. That usually doesn't happen frequently. If the body stays the same and the diet and the sodium intake stays the same, usually once you control with one medicine, most of the time you're going to be controlled with it for a long, long time. Now, if despite what I mentioned, your blood pressure is escaping, then you should see your doctor, because there are things that could happen within your body that are not visible. You've not gained weight, but if you get a blockage in your kidney artery, for example, that is critical, you will have severely high blood pressure even when you're taking a medication that had controlled you in the past. So it's very important that blood pressure starts to change from a previously controlled pattern to a non-controlled pattern, that you see your doctor. Hypertension is a major risk profile for stroke, and it's very easily controlled.
Another example would be somebody is on treatment for hypertension and sleep apnea. They're using the CPAP, but haven't seen the sleep doctor in a while. Now their blood pressure is elevated. So just because they're receiving CPAP does not mean that they're getting optimal therapy, one. It does not mean that the oxygen levels are not dropping, too. So the efficacy of therapy.
Unless it's well titrated, exactly. That's a great point.
Thank you, Christine, for your kind comment. I'll share that with Drs. Khatib and Lamba as well. Elsie asked, how does COVID impact research visit protocol?
it's all standstill right now. We haven't enrolled a single patient in any clinical trial in the past 6 weeks. And this is nationwide pretty much.
But that said, though, I mean, for those who are already in research, we have transitioned their visits to virtual, like we've done in the office. And COVID is going to be with us. It's not just, you know, we're not talking about one plateau here. COVID is going to be a new way of life. This virus is going to be here to stay. Now, hopefully we get the vaccine and the medication that they do work, but the virus is not going away, and we're going to have to readapt back into ways of living, including research, re-enrollment, because it's crucially important. Life cannot stop. We just have got to do it differently.
All right, anyone else have any questions? Going once, going twice.
I thought I had a question typed. This is John Eccleston. I was going to ask, how does a patient, does one enter these trials and at what locations?
Okay, so we send out flyers and information, but a good place would be to start would be here at the office is our information, which the phone number at the bottom of the screen. Yeah.
Very well, thank you.
Absolutely, absolutely, Mr. Eccleston.
Anyone else? Last chance. All right, thank you guys so much for joining us on your Thursday evening. Please stay safe out there. And we'll be sure to send the recording and the presentation and all of the info in an email, so stay tuned for that and let us know what you would like to hear about next. Thank you. Safe evening, everyone. Good night.
Have a good night. Thank you.
Okay, then what you're going to have to